Okay, so today I'll be talking on PCOS beyond fertility, obesity and metabolic syndrome. So I'm going to cover the relationship between PCOS and metabolic syndrome. Bukan metrostenosis, medical based people. Pathophysiology of PCOS and metabolic syndrome. Where does the overlap occurs? And some clinical evidence on weight loss therapy and all. Okay, so in metabolic syndrome and PCOS, is it interrelated? Okay, they are distinct clinical entities. Okay, that means to say, if you are metabolic syndrome, you can be pure metabolic syndrome with no PCOS, and if you are PCOS, you can be PCOS with no metabolic syndrome. However, a lot of patients will have an overlap, and where does this overlap happen? It happens two things. One is insulin resistance, the other is abdominal obesity. Okay, so we're going to talk about insulin resistance and abdominal obesity. So adult women with metabolic syndrome, studies have shown, long-term epidemiological studies have shown that their risk of developing developing cardiovascular disease is higher. That's the whole reason people talk about metabolic syndrome, because they want to see what are your risks of getting stroke, myocardial infarctions, in later life. And women with PCOS also appears to carry this increased risk. When they studied the ladies from young days, reproductive age group, and they are PCOS patients, and they carry on epidemiological studies later until they are in their 50s or 60s, shows that women who are diagnosed with PCOS earlier in their age carries this higher risk of cardiovascular morbidity and mortality as well. Okay. Alright, so we know this. And in adolescents, metabolic syndrome occurs in about 1/3 of PCOS, whereas in adults it's nearly half. And Caviello in 2006, he produced in JCEM, showing that he pulled a few studies and showed that observations among obese women with PCOS, the metabolic abnormalities related to the insulin resistance and obesity were thought to be more important than the mechanisms of anovulation in PCOS than the androgen excess. So what is insulin resistance? Okay, insulin resistance is a state, is a condition when the muscles, the body fat and the liver starts to resist or ignore the signals that the insulin is trying to do, which is to move the glucose out of the bloodstream into your cells. Okay, so how does this insulin resistance develop? It can be due to genetics, it can be due to aging, ethnicity. Some, like the Pima Indians, have higher risk of resistance compared to everybody else in the world. And then it's your excess in body weight, obesity, and of course the dietary choices people make, and the sedentary lifestyle, and also smoking, alcohol, and sleep deprivation. So all this comes about. Okay, this is not to show you the type 2 diabetes, but more to show that this insulin resistance is because of lifestyle factor as well as genetic factors. So you can actually prevent even if you have genetic factors, but lifestyle modification is there. This is a disease which can be prevented. Right, so what is PCOS? Dr. Hatta has explained in detail regarding PCOS, but from medical point of view, endocrine point of view, it is insulin resistance at the pelvic level. Okay, so this insulin resistance appear not to affect only the obese but also lean. That's why I showed the picture for you just now. So these women may be predisposed to develop metabolic syndrome independent of obesity, although the majority will have obesity. Right, okay, we won't go into this. So the etiology of PCOS has been covered by Dr. Hatta just now. Resistance, hypoandrogenism, and defects in insulin secretion. So we're going to go into detail how this comes about. So the pathophysiology, again, in hyperinsulinemia, there's defect in the insulin action or secretion, which will lead to excess androgen excess in the ovaries and adrenals, and later this feedback to the pituitary will cause rise in LH. And what are the effects of hyperinsulinemia? Number one, it decreases your sex hormone binding globulins. So there will be more of free androgens. Okay? And this increased unbound androgens, we know the mechanism is to produce estrogen, but when you have increase of testosterone, that is when all the problems will happen, because the feedback will not be so great. Yeah, there will be reduction in your HDL, and there's risk for PCOS and acanthosis and later diabetes. Okay, so let's look at this diagram. If you have insulin resistance, it means just now we look what resistance was, right? So in somebody with who's overweight, who has got many risk factors, who's not exercising, not taking enough, not doing exercise, not taking healthy food choices, the obesity, the abdominal obesity will happen, and that is thought to be one of the mechanisms which trigger. So in insulin resistance, we know insulin is for formation of fat cells. It's lipogenesis. It promotes lipogenesis, right? But in insulin resistance, although there's excess of insulin, the anti-lipolytic effect will not manifest. That means the anti-lipolytic effect or lipogenesis will not be there. So it promotes for lipogenesis to happen. Okay, so in lipogenesis, what happens is the triglyceride will break down into free fatty acid and glycerol. Okay, so this excess free fatty acid is actually a marker of insulin resistance. The breakdown of triglycerol into free fatty acids and glycerol, the glycerol will enter the pathway in the liver to produce, it is a substrate for gluconeogenesis, which means there will be more sugar raised in the body, production of sugars. Okay, and this free fatty acid state is also lipotoxic, because it will also promote for more resistance to happen. So what happens in this increased adipocytes tissue is the very high free fatty acids will make the fat cells saturated. Yeah, when it makes the fat cell saturated, it doesn't produce the good adiponectin anymore, which is supposed to be protective. Yeah, instead it produces very bad adipocytokines, which is atherogenic promoting, has got interleukin, has got tumor necrosis factor. That's why when we talk about metabolic syndrome and PCOS, the common denominator is the abdominal fat, abdominal obesity, and these patients have a lot of these fat cells, which promotes for the interleukins and the TNFs, and those are the reasons which promote for cardiovascular disease progression. Okay, right? Okay, so when the so this increase in free fatty acid from the adipocytes, it will cause further resistance, and then the fat cells are too big, they cannot cope with the fat content. It sort of spill over into the liver, spill over into the pancreas, spill over into the muscles. So that is when you get your fatty liver, your non-alcoholic fatty liver disease. That is when you get at the pancreas level, it will impair the potential for insulin secretion, so there will be less insulin secretion, and this progression will later lead to diabetes mellitus. Okay, alright. So, but in terms of PCOS, what it does is, because the liver will also be impaired, there's already resistance there, there's reduced sex hormone binding globulins, so there will be increase in androgens. Yeah, and this increase in androgens will actually this increase in androgens, so the pathway should be going on. This is from the theca cells, it should go on to the granulosa cells and produce estradiol, but this increase in androgens will give a feedback to the where's my pituitary? To the pituitary gland, and instead of the rise in LH for ovulation, this chronic hyperandrogenic state will lead to increase in LH all the time. Okay, so there is no surge because the LH is already very high. Okay, so it will lead to this. This is normal menstrual cycle. One follicle is promoted for growing, it will come out, and then progesterone will take over after that. If conception doesn't happen, then you'll have your menstrual bleed. But remember, the surge is there, the LH surge. Whereas in PCOS, because of the chronic hyperandrogenism, which gives the feedback to the pituitary to produce increased LH, then you get all the cells there and nothing is coming out. It's like houseman enter posting, tapi asyik duduk repeatedly tak pass Viva, duduk saja dalam tu, tak graduate jadi MO, kan? So it's something like that. Alright. Okay, so that is why you get reversal of LH to FSH in PCOS. Okay. So Nestler drew up this in New England Journal, and his postulation was insulin stimulates PCOS sticker cells through the insulin receptor rather than from the IGF-1 receptors. Okay, and this hyperinsulinemia, it augments the LH stimulation, so it upregulates the LH binding sites and enhance the androgen production in response to the LH. So it's like a chronic cycle where it doesn't progress to produce higher estrogen and lead to the surge. Okay. Okay, so this is basically the same thing. So why are we concerned? So now we've known how the fat cells are involved in abdominal obesity and the insulin resistance, which is the common denominator for both PCOS as well as metabolic syndrome. So why are we concerned about metabolic syndrome? For the reasons that I have stated before. It puts the patient at a higher risk for CV events. Okay. So this metabolic syndrome component, so now you can explain everything here, right? Because of low estrogen, there will be osteoporosis. Because of the insulin resistance is there, the glucose intolerance, why the lipid abnormality happens, and also the PCOS is part of the metabolic syndrome phenomenon. And this increase in the fat cells, when it enters into the blood vessels, it promotes for accelerated atherosclerosis. So people will tend to get coronary artery disease manifestation faster. And because there is a predominance of small dense LDL cholesterol, I will show you in a later cartoon. So this metabolic syndrome, one of it is the insulin resistance lead to all this. Ectopic fat accumulation, again what we have spoken about just now. Okay, so again this is also a summary of what happens. The adipose tissue, even in guidelines which showed the different metabolic syndrome criteria, the 3 out of 5, a few guidelines, international guidelines, states that you have to have abdominal obesity, whereas some guidelines are not so strict, but it is believed that this increase in adipose tissue saturation is the culprit which leads to lipotoxicity and all the concurrent diseases that it can promote. Okay, so we all know that okay, maybe I should show you. This is just the different guidelines. It takes into account different levels, but this is the definitions for metabolic syndrome for women according to WHO everything. The central obesity defined for ethnicity. So in Malaysia we are using 80 centimeters waist circumference. And the TG is more than 1.7, HDL is less than 1.3 to make a, and also the blood pressure whether on treatment or it is above the recommended level, and also evidence of impaired fasting glucose or previously diagnosed type 2 diabetes. So this is the harmonized criteria which is this all came earlier, and the harmonized criteria is supposed to harmonize all the differences in the some halfway punya methods lah. Alright. Okay, so again, back to what we were talking just now, insulin resistance as well as obesity leads to all this oxidative stress and metabolic syndrome, and it will code for atherosclerotic cardiovascular disease as well as type 2 diabetes mellitus. And there is another missing Venn graph there, which is your PCOS. Okay, so yeah, this is the changing women's health paradigm in PCOS. Initially, it was a problem of reproduction. Then later on, it became a metabolic disease where there will be cardiovascular risk and type 2 diabetes, and also cancer risk. So, obesity, this increase in insulin, I said it's anti-lipolytic, right? So it will promote for fat cells accumulation. So this stimulation appear to contribute to worsening of obesity in PCOS, yeah? And 1/3 or more of normal weight women, so these women, remember the first graph tadi? Although they are normal weight, but they have a preponderance towards abdominal obesity, which is different from global obesity in obese women, yeah? Alright. And obesity is thought to suppress the gonadotropins independent of insulin resistance. So that's why all this double jeopardy will cause a lot of ongoing problems in someone with PCOS and metabolic syndrome, yeah? Right, so waist circumference known to correlate more strongly, okay? And obesity is recognized to be independent risk factor for cardiovascular disease in adults, yeah? We've gone through here all these reasons, causes of adiposity, and the Anthropometrics either use the BMI, measure body fat waist hip ratio or waist circumference, or measure the percentage body fat in the body, yeah? So this is prevalence of abdominal obesity. This doesn't show girls or boys, but it takes into account. But you can see that as the ages grow, the abdominal obesity becomes more and more, especially after retirement age, yeah? So the breakdown in females, they will have it even earlier on because of childbirth and everything. And because if anak-anak tak habis makan, they will tolong makan, habiskan, you know, then they stay at home sometimes and don't move about. Every time they go to the kitchen or on the way back, they see more food on the table, then they will eat, which is very common in our population. They tend to do that. Okay, so this is looking at underweight, normal weight, slightly overweight, and extremely overweight, the changes that happen, yeah. So I think awareness is because we see a lot of PCOS patients, a lot of fertility issues, but of course my topic is not about fertility, but I suppose creating awareness when they are already around here is very important, especially in the school children, yeah. The adolescent obese individuals go on to become young ladies with obesity issues, and this is a cascade of the problem which really needs to be arrested, yeah. Okay, so the subcutaneous fat versus visceral fat, how does it differ? So the fat under your skin, everybody can pinch their tummy now. The fat under the skin is your subcut fat, okay, whereas the fat that is bad, which produces a lot of interleukin and TNFs and everything, is actually the ones adhering to your internal organs, yeah. So somebody can be having a little subcutaneous fat but a lot of visceral fat, and he is at the highest risk to develop cardiovascular disease, as opposed to this patient with a lot of subcutaneous fat but not much of visceral fat. I will show you another picture later. This is not a so good picture. So you see, these are in males, unfortunately, yeah? But just to show somebody around the same age, around the same weight, around the same height, you can see that the difference in abdominal, the visceral fat is different, yeah. And I think a lot of you have seen this photograph of these two professors before. Both are obesity experts, yeah. Both have got the same BMI, yeah. The BMI is the same, although he looks slightly bigger than him. But when they look at the body fat content, Professor John Yudkin has got 9.1%, whereas this professor from India has got 21.2%. But they say his only exercise is running to the elevator door. Yeah, all right. Whereas he runs marathon, and has a healthy European diet. Okay, so that's to show that even those who are very thin but without exercise and all, we don't know the fat content inside us. Yeah. Okay, so of course these are all the complications. Everybody knows this. And it also, the obesity is also a risk factor for cancers formation. Yeah. So in women with PCOS, 30% will have impact glucose tolerance from this study by Legros, long ago paper. Yeah. And 7.5 have diabetes. And among the non-obese women with PCO, 10.3% have impact glucose tolerance. Yeah. And about 1.5% have diabetes. So it shows that even if you are non-obese, but if you have PCOS, the risk factors are there. The insulin resistance, yeah. And also they have usually abdominal obesity, although the rest of them are thin and lean. So, and in a follow-up, 16% of the women treated for PCO 20 to 30 years earlier had developed diabetes at the age of menopause, yeah. So there is progression. It doesn't stay there. It's not static. Okay. The insulin resistance, of course, is worsened by obesity. We know that. Yeah. And again, many papers have been produced to show that there's about 40 to 50% obese. I think there is a study done in Malaysia as well, right? Which shows a higher ratio. Yeah. Okay. So in individuals with non-obese BMI, a higher waist to hip ratio seen in those with PCO compared to those without. So again, a lot of people stress on the abdominal obesity, even if these women are lean. So the obese women with PCO will have a high level of testosterone and lower levels of luteinizing hormones. Yeah, and obese women with PCO have at least one abnormal lipid levels seen in more than 2/3 of them. Yeah. And coronary artery calcification was increased when they studied, they examined in a small percentage of women with PCO. So again, to show that when you have insulin resistance, it is the adipocytes which increases your free fatty acid and then will lead to the spillover and a lot of triglycerides, and these are all the bad cholesterols in the body. Yeah, and this raised VLDL will interact, and the HDL will be lower and your LDL will be higher, but the LDL here is actually not the normal LDL. It is the dense LDL. When you have abdominal obesity, the triglycerides will be higher and the HDL will be lower, and the risk of coronary artery disease increases in this lipidemic phenotype. So that is atherogenic, not the common LDL. Yeah. And again, I stress hyperglycemia, insulin resistance, and ultimately insulin deficiency will lead to disturbance of lipoprotein. Yeah. That's why in Steno 2 it states that if you want to treat a diabetic patient, don't be glucocentric. Okay. Look at them as a whole, treat the lipids, treat the obesity, and also treat the concurrent hypertension. Okay, so all this will lead to endothelial dysfunction and smooth muscle activation, a lot of oxidative stress. Remember the graph just now, the two big vents, yeah? And later, all these components, all the interleukins, tumor necrosis factor, nitric oxide, whatever small, will lead to atherosclerosis formation because there will be reduction in your NO. Yeah. And cardiovascular disease in PCOS. Okay. The combined risk factors for metabolic syndrome in PCOS, there's a 7-fold increase. Yeah, 7-fold increase in risk of MI in women with PCOS if they compare it to match controls. Yeah. And CV disease is well supported by large epidemiological studies. Yeah. And it states here in PCOS, the studies based on menstrual abnormalities, which would mostly but not exclusively be caused by PCO, showed increased cardiovascular and diabetes related death. Yeah. So I would just like to show this graph to show that if we do not arrest PCO at insulin resistant state, yeah, and they go on to develop diabetes with all the micro and macrovascular complications, then once they develop diabetes, then your mortality risk is the same. Look at this. This is diabetes and no cardiovascular disease. Of course, this is not a breakdown into men and women, yeah, overall. This is diabetes and cardiovascular disease. So the mortality rate is highest. This is no diabetes, no cardiovascular disease, yeah. And this is the ones in yellow is diabetes but no cardiovascular disease, and the ones in green is diabetes and cardiovascular disease. So you see, this is why people term diabetes as a MI equivalent. Alright? Because the graph is almost similar. Alright? And this is dividing into women and men. So you can see again, it is the same as our graph just now. Yeah, the mortality risk is running a similar course. You see these two, no DM with cardiovascular disease and DM with no cardiovascular disease. So again, similar even in women. And up to 27% of premenopausal women with type 2 diabetes have PCO. Apparently so, when they come for PCO, it is mandatory that we screen them for diabetes mellitus, even if they do not have acanthosis nigricans and all. Yeah? Alright. But just to stress that insulin resistance itself does not lead to PCO in the majority of women with type 2 DM. So you might be obese, you might have insulin resistance, you might have DM, but you are very fertile, right? Which is another spectrum that we see. So the insulin resistance hyperinsulinism is a major extra ovarian factor, okay, in the steroidogenic dysregulation and DM related comorbidities. So again, everything boils down to insulin resistance. Yeah, it keeps all these papers shows insulin resistance, and once you get the diabetes, then the micro and macrovascular complications will happen. And this is the Asian subgroup in the advanced trial, which shows in Asians, if you develop diabetes, then there will be increased risk of stroke and renal endpoints, yeah, compared to Eastern Europe or other countries. So you see the line in red is Asians, so CVAs are higher and nephropathy events are higher, yeah. Okay, so in women with PCOS and type 2 DM, specific therapies can address both these diseases, yeah? And by reducing hyperinsulinism, of course, you increase your menstrual cycle and androgen. So therapies for PCOS, again, it is back to weight loss, yeah? By lifestyle modification. When we want weight loss, hypocaloric diets, usually 1,000 to 1,200 kilocalories a day for as little as 8 weeks. Yeah, don't go lower than that, because if you are on very low calorie diet, then your risk to produce ketones are higher. It needs close monitoring. It can be done, but it needs close monitoring. But as outpatient, telling the patients and all, we usually suggest these low calorie diets. Yeah. And diabetes prevention program showed that the most effective method to prevent progression from impaired glucose tolerance to avert diabetes is lifestyle modification and diet. So there were 3 arms, yeah. There was the metformin arm, the intensive diet and exercise, and the conventional arm. The ones which did the best was the intensive exercise and diet control. So about 58% risk reduction to progression of diabetes, yeah. The metformin arm, while effective, it only reduces diabetes risk by 21%. Yeah, and there are other evidences. These are all diabetes prevention program evidences. Yeah, to show that with interventions, diet and exercise, you can actually reduce. But of course, as Dr. Hatta said just now, we cannot just balik exercise. Yeah, there must be exercise prescription. It must be a team effort. Everybody must sit down and tell these patients on how to go about eating lesser diet, lesser food, lesser calories, as well as doing exercise. So I was very lucky when Putrajaya, Dr. Masni here is my guru, taught me a lot of things about obesity, which I'm applying here, and it seems to work if the patients really want it. If the patients Just now Dr. Hatta mentioned a few things, but I think the most important thing is patient must be motivated. It's no point we tell the patients, you must lose weight, 2 more minutes please, lose weight, you know, if they are not motivated, they will be motivated when they come to see you. 2 weeks later, their motivation will go down the hill. So you need them to come constantly, keep motivating, tell them, do support groups, see when other people are losing weight, how it affects them, yeah? Because when you do these support groups and all, everybody has the same problem. So they can share willingly their tips and everything, yeah? We have had one lady who lost from 130 kilos down to 70, now she's 59 kilos, just based on diet and exercise alone. There is a man with 311 kilos, I think Mr. Najmi is here. He lost 83 kilos. He was down to 230 before going for bariatric surgery, and after that he lost another. He is now down to 150 kilos. So it's not like surgeries are not like pricking the balloon and they go down. Yeah, it is because you already. Most patients have the idea buat operation akan kurus. No, it is a lot of hard work. It involves a lot of discipline. So if patients are not motivated, you can never reach the target. Yeah. Alright, so again, therapies include metformin. Of course, from our side, we are slightly different from ONG. We believe that because we do not have access to clomiphene and all, so we might try metformin, yeah, to increase the peripheral glucose uptake, and it doesn't cause weight gain, yeah, and it will restore back menstrual cycle. Okay, so in summary, obese women with PCO are at a higher risk to develop diabetes, yeah, and they are more dyslipidemic, and PCOS patients worsen with weight gain, so we should aim for weight loss to treat the PCOS, because this constellation of metabolic syndrome and PCOS coexist, yeah. And of course, they share insulin resistance and abdominal obesity as its central feature. So if you remember nothing from this lecture, just remember metabolic syndrome and PCOS, the thing in common is the insulin resistance and the abdominal obesity. But not all PCOS have metabolic syndrome. Concurrently, not all metabolic syndromes have got PCOS. Yeah? And in conclusion, PCOS and metabolic syndrome have the common feature of insulin resistance, which is central to trigger all these consequences of the disease. And later progression to the CV disease. So with that, thank you very much for your kind attention.